So next we have Dr. Sheetal, who's going to talk on post-refractive surgery IOL power calculation.
Thank you, Dr. Shreyas, and I would like to thank Dr. Sri Ganesh for this wonderful opportunity. Good morning, friends. I'll be talking about post-refractive surgery IOL power calculation. This can be daunting sometimes, and this is a bit of a theoretical topic, so please bear with me. So there can be three types of errors that may be causing problems with IOL power calculation post-LASIK. The first error is the instrument error. The second error is the refractive index error, and the third is the formula error. So instrument error basically refers to the error which arises from the use of standard keratometers. So what happens is when you use standard keratometers for corneal power measurement after LASIK is that these instruments cannot accurately measure the corneal power post-refractive surgery because the keratometers essentially measure the paracentral points at 3.2 millimeter zone and they miss the central flatter zone. So we know that post-refractive surgery, especially the myopic surgery and also hyperopic, the maximum change in the cornea occurs in the central 3 millimeter zone. So this is the area which is kind of not measured accurately, and hence this can lead to overestimation of the corneal power and a resultant hyperopic shift. Refractive index error. Basically, again, if you use keratometers and topographers only to measure the anterior surface of the cornea, and they basically convert the radius of curvature to diopters using this formula. And the refractive index which is used in this formula is 1.337, which is a fixed refractive index to allow contribution for the posterior surface. Now, basically, this refractive index is used when assuming a normal or a constant relationship between anterior and the posterior surfaces of the cornea. Now, after refractive surgery, this relationship changes because the anterior surface flattens and there is no change in the posterior surface. So, this refractive index does not hold good, and hence you can have errors with the IOL power calculation. Formula error is basically the error that arises due to problems with calculation of the effective lens position. Now, following LASIK, corneal curvature changes, as we all know, and due to this, the effective lens position can be wrongly estimated. Now, the third generation formulae which we are using, like the SRKT formula, Hoffer Q, Holiday 1 formula, basically these formulae, they they calculate ELP. Basically, the ELP in these formulae is dependent upon the change in the curvature, and also they depend on the axial length. So since the curvature changes, it flattens. So these formulae estimate the position of the IOL much more anteriorly, and hence they suggest a lower powered lens, which leads to hyperopic surprise. And it has been found that 1 millimeters of error in effective lens position can result in up to 1.5 diopters of change in the final refraction. Now, what are the methods to obtain true corneal power after refractive surgery? So, there is clinical history method, which is still considered to be the gold standard, contact lens over refraction method, topography based post LASIK adjusted keratometry, central ring topography method, and net corneal power measurement. So clinical history method basically was proposed by Holiday in 1989, and here basically how you derive the central corneal power is by adding the mean keratometry power before surgery and the spherical equivalent before refractive surgery, and then subtracting spherical equivalent which was there after the refractive surgery. So this theoretically yields the actual corneal power, is also easy to calculate. However, the accuracy depends upon the accuracy of the data. If you do not have pre-refractive surgery data, then you cannot use this, and it is also not suitable for the RK eyes. The contact lens over refraction method was proposed by Ridley, and in this method, basically, you calculate the corneal power as the sum of the base curve of the contact lens, the power of the contact lens, and the over refraction minus the spherical equivalent of the manifest refraction without a contact lens. Now, this is inexpensive method and is also suitable for both post LASIK and RK corneas. However, it suffers from the disadvantage that its accuracy reduces with the poorer visual acuity and is also not suitable for denser cataracts. Then we have the topography based post LASIK adjusted keratometry. Now, in this, basically, the true corneal power is predicted using a single central post-op reading on the topography machine. And under this category, we have the Koch and Wang formula and the Sharma's formula. These formulae are available on the ASCRS website. So these formulae are regression formulae based on LASIK data and hence are also not suitable for post RK eyes. Then we have the central ring topography method. This is the method which is suitable for post RK eyes. So it averages the topographic corneal power of the central 3 millimeter area. And when you apply this with the double K formula, it gives excellent predictability. Then you have the net corneal power measurement that takes into account both the anterior as well as the posterior corneal surfaces. And this is useful when you do not have any refractive data available. So you can use the pentacam or you can use the optical coherence tomography methods. The true net power in the pentacam is the one which is most commonly used. So now what are the different IOL power formulae that can be used post refractive surgery? So you have this very famous formula, which is the double K formula proposed by Aramberry. So in this, basically, this is done to improve the accuracy with the third generation formulae. So as I said, that third generation formulae depend upon keratometry and axial length for ELP estimation. So what it does is basically it uses the post refractive surgery corneal power for the actual power calculation and the pre refractive surgery corneal power for the ELP prediction. So and you can have these adjustment tables or the correction tables which are available on the drhill.com, from wherein you can derive the IOL power calculation. Also, the Hagee's L formula, which is also quite useful. This is available as part of the built-in software of IOL Master, both 500 as well as 700. And this is a regression-based formula based on the statistics. So accuracy of this formula may actually decrease if the eye is on the edge of the normal distribution, say a very highly myopic eye or highly hyperopic eye. So it may not be very accurate. It is also based on the LASIK data, hence not suitable for post RKIs. And then we also have the Masket formula, which adjusts the power of the IOL using post-op measured data and knowledge of the surgically induced refractive change. Now, online IOL calculators have actually made our life very easy. They are fairly predictable and handy to use. So you can find these formulae on different websites, iol.ascrs.org, ilab.com, the Hoffer program website, and the drhill.com website. So ASCRS website is one of the most commonly used and is a very popular website wherein you can use this IOL calculator for eyes with prior myopic, LASIK or PRK. So what you need to do is that you can enter whatever data is available with you, even if you have any pre-refractive surgery data or not. You can enter all the data, like the refraction, keratometry. Also, if there you have topography, then it also caters to a lot of topography systems, wherein you can have the ISIS, the TOMI, the Galilee, Atlas, Pentacam, even the RT view. So whatever equipment you have, you can measure the cornea, the corneal power, and you can enter the values here. And based on whatever data you have entered, it will suggest IOL power using different formulae, like the Sharma's formula, Hagee's L, and the Musket formula, etc. Then you also have the APSRS website, wherein you have the Barrett True K formula. This is a very popular formula which works for most of the post LASIK situations, hyperopic LASIK, PRK, myopic LASIK, PRK, and even post RK eyes. So this is based on the Barrett Universal 2 formula, wherein it calculates a modified keratometry value for post refractive surgery eyes, and it also provides a double K solution when the central Ks have been altered. So here you can see that this formula is quite easy to access. And then we also have the holiday EKR detailed report, which is available in the Pentacam. So both post myopic and hyperopic LASIK eyes, basically you can use this report, and you can use the 4.5 millimeter EKR zone K values, which are here shown in the middle. And these values have been shown to have high correlation with the central corneal power calculated with the clinical history method. So I said clinical history method is still considered as the gold standard. So these values in this zone, they kind of correspond with this method. So this zone is selected for K values. And you can also see that there is this graph on the left side. So if you see this peak as a single peak with Gaussian distribution, then the cornea is the keratometry is fairly well distributed, and you can also implant a multifocal lens in these eyes if the peak is a single peak like this. And you need to use a Holiday 2 formula with this report. Then we have the total keratometry. I think Dr. Shreyas has already discussed this. I'll not go into details and how it is calculated. So basically here, you don't have to assume the posterior curvature. You already directly measure the posterior curvature. So it provides better accuracy. The Barrett true K formula can further be improved by use of the TK values. And Dr. Graham Barrett has also found in his study that with the use of this formula, the outcomes had further improved. Then we also have the ray tracing, which is the latest, and we have the MS39, wherein we use the ray tracing. The keratometry basically is measured by the ray tracing, and then what you need to enter is the axial length from your IOL master or any other from the immersion. Also, you need to enter the target refraction, the pupil diameter, and A constant of the implanted lens. So this also has been found to correlate with the, like, it works as par at par with other formulas such as the Barrett 2K formula. So just showing a case, this case had a post-myopic smile 3 years ago, and he had a rapid onset of diabetes, and he developed NS grade 2 in both the eyes. This was his refraction, and this is the pentacam. You can see this is a bit central flattening, which looks fairly regular on the axial map. But when you see the Holiday EKR report, you see two peaks there, so it's not really very regular. So we thought it is better to implant a monofocal lens in this case. And this is the Zanicke analysis. Corneal abrasions were also on the higher side, so we decided to perform biometry for Zeiss CT Lucia, which is a monofocal lens. And we checked with different formulae, and here you can see on the top the three formulae are the third generation formulae, and then the ray tracing, Hagees L, Holiday 2 with EKR, and Barrett 2K and 2K TK. They are all specific post refractive surgery formulae, modern generation. And here you can see that with the newer formulae are actually giving almost the same refractive, same IOL power as plus 22.5. And this is quite different from the older formula. You can see the older one are 21.5, and here the IOL suggested is 22.5. So almost 1 diopter difference. So we went ahead with 22.5 diopters. Post-refractive, post-surgery at 2 weeks, 4 weeks, the residual refractive error was 0.25 diopter of SC. So then we found the predicted post-operative refraction and the predicted error. And with this, we can see that the newer formulas, the error is much less compared to the older formulae. And out of the newer formulas, the Barrett 2K TK has the least prediction error. So to conclude, in post-refractive surgery cases, use more than one method to measure the central corneal power, use more than one formula to calculate the IOL power. It's better to hedge in the direction of myopic results in post-myopic LASIK eyes, and emmetropia and slightly hyperopia in the hyperopic LASIK eyes. Total keratometry-based formulas provide better and accurate results. However, it is still advisable to warn the patient and counsel the patients about the potential need for refractive correction after cataract surgery, since there are so many variables which are not under our control, and refractive results can still be off. Thank you so much for your kind attention.
Thank you, Dr. Sheetal, for a very comprehensive talk. You ran through so many different formulae and calculators. Today, if you were to operate on a patient post LASIK, post smile, is there any specific formula or calculator that you would advise?
Barrett true KTK.
So
That's the one formula that works very well for all situations.
So I think things have really become simple for all of us now. I mean, while it's a good idea to have the understanding of the theory and why these changes are required, but now the entire Barrett suite can be used for any type of patient, whether it is post LVC, post RK, or previous different types of ablations. All of them work extremely well with the Barrett True K. We have almost stopped even looking at the ACRS or other calculators nowadays, and the Barrett True K, and if you have the TK with you, the Barrett True K TK works even better, and excellent results that we are able to achieve with them. You are even able to have the confidence to implant multifocal IOLs in many of these patients because the biometry is spot on.